so pleased to be here because this continues our effort from the Institute of Medicine, those of us who served on the committee, to reach out and partner with others to kind of move these messages forward. Because as you were saying, there are a lot of things that we currently are not doing that we potentially could do. One of the things that struck the committee, because I was one of the non-pain experts who served on the Institute of Medicine committee, there were very few of us non-pain experts, but I certainly learned a lot. One of the things that really struck us is when we had a discussion about the amount of training that medical students receive in regards to pain management. What we found out was that the amount of hours that they receive is less than veterinarians get during veterinary school. That's really striking, isn't it? That veterinarians get more training than physicians do in terms of pain management. So I'm going to talk about just a sliver of this overall story that's highlighted in the Silver Book. The Silver Book talks a lot about the Institute of Medicine's report. In fact, you'll notice it's referenced in several places because we had a very lengthy period of time to develop this report. We had a lot of experts who were involved. We had a cost analysis that was done. We reviewed a lot of data that had never been previously analyzed or presented were included in that report. What's nice about the Silver Book, it is definitely, as you can see, much easier to go through, right? Much easier to go through. So those of you who want to delve a little bit more certainly can go to the IOM report. So just want to tell you I have no financial disclosures to give. And here's a picture of the report again. A little background. You were part of this. The legislative process was part of establishing a need for having this report. In 2010, the Patient Protection and Affordable Care Act called for the Department of Health and Human Services to have a report that examined pain as a public health problem. Not a clinical problem, a public health problem. This was a very different mindset about how we were going to approach it. What should we do on a population basis to address pain? Not only to prevent it, but also to better manage it. Our study committee had a wide range besides just two epidemiologists, one of which was not a pain expert, that's me. We also had people who were expert in anesthesiology, palliative medicine, pediatric health, a wide range of disciplines that were expressed there. I do want to take just a moment to talk about what is pain. You heard some wonderful discussion about the importance of understanding that it's the perception of pain is what we're talking about. Well, we came up with this definition. We thought this was the best definition when we read multiple definitions out there. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Pain is always subjective. Again, hard to measure. So what is pain? We've got two different sort of camps we can put them in. We've got the acute pain, sudden onset, you stubbed your toe, okay, lasts a short time. Chronic tends to last longer, typically 3 to 6 months. We don't have a standard definition, which makes collecting the data very challenging. But chronic pain is understood to be difficult to treat. It can result from underlying disease or injury or medical treatment or inflammation. And sometimes the cause may be unknown. So who is at risk? All of us in this room are at risk. That's important to understand. The examples of pain-related conditions, acute could be wound infections, for instance, childbirth. Chronic could be migraine, back pain, etc. We know that the risk of these various types of pain do vary by many factors, including age, race, ethnicity, gender, income, education, other socio-demographic factors. We felt there were some important key messages after review the data, and we had extensive public workshops and public comments. We received over 2,000 comments written in by pain patients and individuals who either live with someone who's living with pain or else treat somebody with pain. So we found that 100 million estimate that we're giving, that's just adults. It doesn't include the kids. It doesn't include the military. Those who are veterans sometimes are not included. It includes people who are living in civilian, non-institutionalized population. Okay, that's what the survey data collection refers to, and it doesn't include kids, as I mentioned. It definitely reduces quality of life. Large dollar amount, as you heard, $560 to $635 million annually. We need more consistent data. We're not even using the same definition of chronic pain, persistent pain. We need it to document rates of treatment and undertreatment. Now we have the Affordable Care Act, other efforts to incorporate healthcare reform. hopefully there are going to be some changes in terms of prevention. We want to see whether that is indeed making an impact in terms of the rates of pain as well as management of the pain. We need it to also to assess health and societal consequences. We need a population-based strategy. So let me give you one example of one that we ran across. Low back pain. In Australia, they did a media campaign for low back pain with very simple messages that were telling people that low back pain is very common. That doesn't mean that you should immediately rest, that you can continue with your usual activities. And they found just this media campaign, they were able to see documented drops in costs in many different ways. So we were thinking, this is not only just affecting the people who currently have pain, but this is also preventing future costs down the road too, if we can communicate these messages. So that's what we mean by population-based strategy, not just one that's focused on patients, but looking at the broader population. Informing the public about the nature of pain, and that's one of the things that the Silver Book is helping to communicate. So some of those economic costs, you heard the big dollar amounts, but breaking it down, that includes days work missed, hours work lost, lower wages, and the incremental cost of healthcare. So the actual cost of healthcare is just a portion of it. When we're talking about the impact, the economic costs, it's much more on society than just the healthcare costs. The scope of the problem, about 43% of U.S. adults have a common chronic pain. In fact, many of us are probably sitting up here feeling a little bit achy, and you sitting back there also probably feeling the same. In terms of who has low back pain and what types of back pain, of a chronic pain, low back pain is one of the more common forms. Knee pain is another common form. Severe headache or migraine is another common form of chronic pain. But their key shortcomings is, I said, we don't have standardization of our definition of what is chronic back pain. We don't have standardization of how we ask the questions about pain. We have existing international standards such as low back pain, but we're not using those existing international standards in our U.S. population-based health surveys, even if they do exist. Our national surveys, as I mentioned, don't include military, chronic care facilities. We're only asking questions about adults. We have no information about kids, about the level of pain within kids. And when we do ask about specific conditions, we don't ask about everything. For instance, we have data on arthritis, but we don't have regular data collection on lupus. Longitudinal data on the consequences of pain are also not available. We know there are a large number of populations that are undertreated. They range from certain racial ethnic minority groups, women, children, elderly, military veterans, surgical patients, cancer patients, people at the end of life. And in fact, the Institute of Medicine now, with your guidance, is tackling end-of-life issues. And the main person who is responsible for leading that effort, main staffer at the Institute of Medicine, is also involved in that. So there is consistency between the two reports. Now, we did have some recommendations, and after you review this report, you may want to revisit some of those recommendations. One of the things we were saying is there's a need to improve the collection and reporting of data on pain. Everything from the incidence and prevalence, finding out the new numbers and rates of pain, but also how many people are living with pain, to costs of pain and pain care, effectiveness of treatment, and we called for a comprehensive population-level strategy for pain prevention, treatment, management, and research. And I'm pleased to say there has been follow-up on that. There is an interagency pain research coordinating committee that has been reinvigorated, and that has recently been tasked with implementing that recommendation, coming out with this comprehensive public health strategy. So thank you.